I'm going to introduce the next speaker, who I have met before. It's my colleague Dominic Slade, and I'm delighted to welcome Dominic to the podium to give the Brian Brook lecture. And I've deliberately chosen a subject which is, I know, extremely important to many patients in the Ileostomy Association. Dominic Slade is one of my colleagues. He graduated from the University of Birmingham in 1992, sorry. I know it probably feels like 1922 at times in medicine. And after completing his foundation training, he worked in Western Australia. And then, despite having worked in Western Australia, he still decided to come back to Birmingham, which was remarkable. He taught anatomy to medical students at the university here. And then during that process, he decided to train to be a surgeon. And he came to Manchester for basic and specialist surgical training. And I think I met Dominic actually during his specialist training, actually. During this period, he completed specialist training. He came to work with us. We were very impressed with his skills, his communication skills, and in particular, how patient-orientated he was, which is very important. He actually became not only a colorectal, but an intestinal failure surgeon, and there are very few specialist intestinal failure surgeons in the country, probably less than, there are many people who claim to be, but there are probably only about 15 or 20 specialist intestinal failure surgeons with specialist training. But what Dominic did, which I think is really special, and which is one of the reasons why he's been invited to give this lecture here, is he very rapidly identified that there were specific problems in relation to intestinal failure surgery, not so much in putting patients' bowels back together again, but in reconstructing their abdominal wall. And he went off and got further specialist training in abdominal wall reconstruction. He went and worked with some really big names in intestinal failure surgery overseas and abdominal wall reconstruction overseas. And he's brought those skills back into his own practice and is now teaching them to others. And as part of that, his development of a specialist parastomal hernia clinic in Salford, and using those techniques to improve the quality of life for patients all over the country with parastomal hernias is something that I felt should be recognised, because I know it would have been an important issue for Brian Brook. I hope Dominic is used to performing cabaret, because while you're eating and drinking, that's what it does feel a bit like, and I've done that before. But it gives me great pleasure to welcome Dominic Slade as your Brian Brook lecturer this year. So Dominic, please come to the podium.
Thank you very much, Gordon, for that very kind introduction. I am a colorectal surgeon. I'm also very proud to say I'm a general surgeon. In this day and age, many of us try and get so specialised that we forget that we were trained by people like Gordon to do not just bowel surgery, but hernia surgery as well. I have some disclosures. First of all, I'm an NHS surgeon through and through. I don't do private practice, so I'm not touting for business. I have received money to speak for the companies here, all of whom make mesh products. And I've spoken about those in the arena of teaching surgeons how to do operations, and none of that is relevant to the talk I'm going to give. But the bit that I think is really important is that I'm the chair of the Association of Coloproctology Great Britain and Ireland Abdominal Wall Subcommittee, and I've been doing that job for 5 years, and in that time I'm very proud of the fact that we have had 3 patient representatives upon it, and that we also have a stomach care nurse specialist, and it just happens to be Natasha. I try to use ChatGPT like my kids do to sort of create an image that would explain why it is that because this interest in parastomal hernia has come around a little bit along the same lines of about abdominal wall surgery for intestinal failure patients, that it just seems to be done so badly. And And by bumping into patients and then trying to understand that there must be a way of doing this better, then I got very inspired. And I got very inspired particularly by Neil Smart, who has given this lecture before and is one of your trustees, I believe. And Neil is a good friend. We seconded him onto the committee just because of his wealth of expertise. So I blame him for my interest in parastomal hernia. And I'm going to start my lecture at the point that Neil finished in 2017. So he had this obituary that Neil Mortensen wrote about Brian and used it to sort of finish off his talk. And I was fascinated to see that Brian Brook was at Birmingham, and he was a professor in the newly formed academic surgery unit there. I actually went to Birmingham shortly after he finished there, but Jeff Slaney, who was responsible for him taking up that job, was one of your first ever speakers, and an incredible person who really put Birmingham University on the map at the time for surgery. And Brian Brook was the person who described how to make an ileostomy into a spout. And Gordon and I were operating just a few years ago, and we were both remarking about the fact that that didn't happen until 1954, which actually is very recent memory, isn't it? And you would have thought that with all the, the basics of bowel surgery, that something like that would have been thought of before, but it hadn't. And prior to Brian Brook describing that, ileostomies were considered the worst thing to do to a patient because the stoma bags for them and the technology for a bag to stay on didn't really exist at the time. And making a flat stoma, which is what people would do, would cause no end of problems, as some people might know in the audience. So the idea of putting a spout on it was revolutionary and revolutionary to patients. And why it mattered in Brian Brook's practice is at the time people were dying from ulcerative colitis. Adults were dying from ulcerative colitis because it wasn't possible to do their surgery safely. And what he introduced with the ileostomy was a way of staging that surgery and then doing the colectomy portion later, and that saved lives. But by all accounts, Brian Brook was an incredibly difficult man to work with. And one of his key features that Neil picked out was his ability to sort of challenge everything around him and being a convinced anti-dogmatist. And if there's and this slide is just the best place to start for parastomal hernia because dogma, there is too much. So here we go. Now I've got some real pictures of real patients in these slides. All the patients have given consent for me to use them for education, which is what this is, but I would be very grateful if you don't take pictures with your own phones because they didn't consent to that. So what is a parastomal hernia? A parastomal hernia is an incisional hernia. So it's one created by Gordon and I, in a way, because we've made a cut. And the cut then, over time, around the stoma gets bigger, and that then allows a piece of bowel to push through or for a bulge to develop. And it doesn't really matter what you call it. For the individual that has a parastomal hernia, the bulge is the problem in many ways. And there are so many challenges around parastomal hernia, even here in 2025. We don't really know how many people are affected. I mean, we might be able to scan everybody in the room and say, well, this percentage have a hernia, but we don't know how many people are actually having problems from it. We don't know what the best treatment is, really. We don't know what the best way to measure treatments for parastomal hernia might be. And we definitely can improve the surgery for it. And some of that is technology, and some of that is actually improving the quality of the evidence that we have around trying to understand how to treat this condition. And I think there is also a very real question to be asked about should every colorectal surgeon be doing this kind of surgery. So, firstly, how common is it? Well, if you believe surgical dogma and Professor John Gallagher, who is a surgeon in Leeds and a very famous surgeon, and again, I know there's at least one person in the audience who knew him, he, in his textbook, says that basically a parastomal hernia is inevitable. If you leave it long enough, you're going to get a hernia. And the problem is with a lot of the literature is that it doesn't really follow patients up for longer than 2 years. That's a maximum length of time. But we know that there is a risk lifelong because as we get older, our tissues lose their elasticity and something that was a small hole can stretch and get bigger. If we scanned everyone, we'd have a different answer to just those people that can actually see a bulge or a lump. And it definitely depends on what kind of stoma you've been given, what the chances are of you developing this condition. And the question is it a major problem? So if you believe surgical dogma, it isn't. And Park, another very famous colorectal surgeon, in this sort of description of complications from colorectal surgery over a long period of time, reckoned that just about 1% of patients had a late complication. And we know that that's nonsense. If you ask the patient, you get a completely different answer. And of course, that's who we should be asking. So these 3 papers here sort of try and outline what patients actually say. The top one was a questionnaire sent out over a 10.5-year period by the FSF, which is the French version of your association. And they found about 720 patients who actually had a parastomal hernia, so about a quarter of them. And that 3/4 of them had symptoms, and up to a third of them actually ended up having an operation for that problem. In Denmark, they looked back at a whole group of people treated across the country and reckon the incidence is about 60%. And in the UK, this bottom paper here from a stoma care nurse group, but it's actually quite an old paper, reckon that at least 40% of patients got it, and it had a significant impact on their quality of life. Sorry, too far. So another paper from the stoma care nursing group, and this is long before really social media and the internet was developed, so it's historic. But essentially, it seems that an awful lot of patients just suffer in silence. And if they do have a problem, they certainly don't come to surgeons. So, we have to ask ourselves, why are we not in that conversation? And the reason is because they go to the person that they know best, the person that was there from the day that they had their stoma formed and that they continuously see. May not be the same person, but the stoma nurse, and that's the person that they speak to. And historically, and understandably, many stoma nurses have protected patients from people like me because, don't worry, I've not got a great revelation here, because we don't know, as I've said, what the best treatment for patients are. And it may not necessarily be in the best interest of the patient to go and have yet more surgery. So what are the risk factors? Well, these are some of them. There's quite a few, to be honest, but the reason that I've picked these out is the top 2 also represent the changes that are occurring in our population in the UK. We are growing as an ageing population, and unfortunately we're also getting bigger. And those 2 problems are very much related to the development of a parastomal hernia. If you smoke, then that increases your potential for complications at the time of an operation. If you're unlucky enough to have a wound infection at the time of your surgery, and with colorectal surgery that's very common because of bowel, that increases your chances. And emergency operations are always 2 to 3 times more likely to cause you complications than a planned, well thought out operation that doesn't have to be done in a hurry. So, does it matter what kind of stoma you have? This paper here had a small population of patients that they studied, and they saw a trend that if you had a colostomy, it seemed to put you at a little bit more risk of developing a hernia than, say, somebody with an ileostomy, and if it was an end stoma, a bit more risk than a loop stoma. And they then looked back through the sort of literature at the time, and it seems that those trends are borne out. I genuinely can't quite explain to you why there is that difference, but that finding has been proven time and time again. But the thing is about all of this is all the studies that I've shown you up until now are at least 15 years out of date. And they are looking backwards. And when you do that, there is a real problem with the quality of the data that you get, because by looking backwards, you miss patients out. If you try and engage people with a survey, generally human nature is you get some people who respond who've had a good experience or a bad experience, but you may not get the people in the middle. And then there's an attrition related to people moving out of area. They may have had further surgery, and of course people die. And so therefore, if you've got a population of patients, you're probably going to miss some of them in all of those types of studies that we've seen. And the other thing to say is that, the world's changed. So the video that you're watching now, that is the start of a robotic parastomal hernia operation. And that operation causes very little tissue damage. It's very precise. It shouldn't be causing any bleeding, but there is a fair bit on there. And the fact that we're starting to do more and more surgery like that means that the scar tissue that is formed after surgery is different. And in fact, probably, particularly for end colostomies, for people who've had, say, rectal cancer surgery, may actually increase the chance of you developing a hernia. And one paper suggested it might be as high as 18% compared to open surgery. I think that's not actually the case, but it does seem to be that there's a change in the way things are with minimally invasive surgery. So there are so a patient develops a parastomal hernia, and then there are these two sort of opposing poles. There's what the patient sees and hears, and there's what the surgeon feels and says to the patient in the clinic. So from the patient point of view, and I've heard this said from our patient representative on the panel, is that obviously you've been through a big operation and you've been given a stoma, and you adjust to that, hopefully get your life back together, and then somebody develops a parastomal hernia and suddenly all that confidence is swept away, or is affected anyway. And for somebody to then say to you, well, you need an operation to fix that, understandably is one hell of an undertaking and a thought about, do I really want yet more surgery? And there's risk with surgery. No surgery is without risk. And whilst a lot of people come to our clinic and that have been turned down from somewhere else saying, oh, I was told they'd kill me if I did their operation, actually, that isn't the worst outcome. The worst outcome is surviving the operation, but being worse off than you were before you had that surgery. And so that's a very real risk that patients face. And then there's a significant amount of bias, and that bias can be positive or negative. But as I've already said, the first person that somebody might go to is their stoma nurse, and their stoma nurse may say, you don't want to get anywhere near Mr. Slade, that's a terrible thing to do. Or they might say the opposite. There are now patient forums and things that you can access very easily on the internet. And again, just like TripAdvisor, the people that put things on there are often people that have had an excellent experience or a terrible experience, but there ain't much in between, and you may not actually be getting the right information. And then, of course, there may be bias from the surgeon as to what the surgeon might say to you. And then there's the benefits of going through that operation, which may be unrealistic, and I'll try and explain a bit more about that in a minute. From the surgical point of view, the reason why surgeons might be so negative about doing anything more is, firstly, genuinely, and this is not a criticism of any of my colleagues, but it is just the truth, that not everyone is trained to do this kind of surgery. People who are busy cancer surgeons may not be the right people to do your parastomal hernia operation because it's not something that they do routinely or regularly or even had the latest training in. And they may not have the experience either, and I will show you that in a minute. Generally speaking, all surgeons are very scared about mesh next to bowel, and colorectal surgeons particularly, because we know when it goes wrong how mesh can cut into bowel and generate a terrible problem, or mesh may get infected. And yet we know that a good principle of hernia surgery is if you want a durable repair, you need to put mesh into the repair. And surgeons, as I said in Nick Dames's session earlier, we're very focused on when we know that we're doing something and there's a potential for poor outcomes or failure, it tends to make us very negative about the concept of doing it because we don't want to be the surgeon with those poor outcomes. And then finally, the thing that might push a surgeon to push you into having an operation is their perception that the hernia might get stuck and you end up presenting as an emergency and needing emergency operations. And that is a very laudable reason to operate on someone. except it's incredibly difficult to know who that person's going to be. It's not actually that easy to decide who is at most risk of strangulation. So let me try and give you a sense of why surgeons are in the position that they are. This is not a defence, okay? It's just reality. This, and you'll see I've got a few studies from the Danish Hernia Registry, which is an incredible resource of information that was introduced in 2007. Denmark has a population of about 5 million people, and they have very, very good national data collection. So we can be fairly confident that their data is some of the best in the world, and it's really representative of what might go on. And this chart here shows you failure rates for all different types of hernia after they've been operated on, and the one with the worst failure rate is a parastomal hernia. And they said in this paper that over the period that the registry has been in place, that parastomal hernia repairs probably had a 2- or 4-fold greater long-term risk of them recurring. So that's the first thought that surgeons have. And so that means that we tend to put patients into this sort of watchful waiting, or as somebody describes, willful neglect sort of category, because we don't want to do something, especially when the hernia is very small, we don't want to do something that might potentially cause a lot of harm, and we know that there's a chance that the hernia will come back at some point. And yet we really don't know what the risk-benefit analysis of this activity really is. It's just that that's probably safer than saying to everybody, have an operation. And we don't know what the emergency rate of people turning up to A&E, or ED as they call it now, with a strangulated hernia. I trawled all the papers that I've got on parastomal hernia, and the best I could come up with is it might be about 15%, but we don't know. And in addition, over time, some hernias get bigger, but not all of them, and they do it at different rates. But what we do know is that when hernias get very big, you end up having to do a much bigger operation. And maybe that's a bad thing, because if we could keep surgery much smaller and less invasive, then that might be more acceptable to people, and we might get better results. And at the bottom there, I've put 2 comments from 2 surgeons that I know well and that I rate very highly, but it sort of gives you a flavour of why, just how downbeat colorectal surgeons can be about parastomal hernias, because they find it a very challenging condition to deal with. So what if we don't do an operation? Is there anything else that we can offer? So you've already seen, and I know, I believe Sarah Russell is part of your organisation, that there are things that can be offered. We don't know the evidence behind them, but they certainly seem to help, and there's no risk associated with them. So why wouldn't you ask someone to try and lose some weight, because that might help with the symptoms they're getting, to educate them about how to manage their hernia and what to do if it becomes painful or they have symptoms from it, and to prescribe some bespoke belts that can flatten the profile, allow you to wear the clothes that you might want to wear, and give it some support. But again, we don't know whether that slows down the increase in size in your hernia. We don't know what the long-term effect is. And then there's this, which is structured core exercise programs, which definitely improve the patient's well-being. But again, we don't know the sort of what effect does that have long term. But all I can say as someone who does a lot of hernia surgery is that one of the things that I rely on to do a good repair is good quality muscle. So the person who is active and is doing things is in a far better category and likely to have a much better repair. And I would really strongly, I bet there's probably 20, 30 people in this audience who've been told never lift anything heavier than a kettle. I don't know where that came from, but it's rubbish. And basically, as long as it doesn't cause you pain, you're perfectly safe to exercise. In fact, that's a good thing to do. So what about the outcomes of surgery? Again, caution, this is all really out of date information, but at least it gives you some idea again about where surgeons might be when they're thinking about doing this surgery. On the left, a 14-year review which ended in 2011. It's an American population, a big data set, but suggested that planned surgery for parastomal hernia carried a 3% risk of mortality. That's just from a planned operation. And it's not the surgery itself, it's complications that lead to that. On the right-hand side, another American big data set, 3-year period, ended in 2008, so again, a little bit out of date. But interesting because what they were trying to explain was what might be the effect of aging and presenting as an emergency on your chances of dying from having a parastomal hernia operation. And what it showed was that risk, if you're both those things, over 70 and having an emergency repair, is as high as 21%. And yet, if you were to have that operation as a planned thing, then your risk of dying from that operation, even if you're over the age of 70, is reduced by a factor of 10. So that sharpens the mind a little bit about thinking a bit more pragmatically about how we might actually reduce risk and do safe surgery. This paper I find fascinating. It's from Sweden, another country that has very good national registry information, and it finished in 2007. It's a 9-year period, and in the whole of the country, they maintain that in that 9 years, just 71 parastomal hernia repairs were done. I can't believe that that's the case, but I think what it's trying to explain is at that time, it was considered such a poor operation to do that basically very few people were offering it. But the other part of the paper that's very interesting is that as a result of them doing so few planned operations, that 31% of the people who had these repairs were pitching up as emergencies. And just hold that thought because it's really relevant to the remaining part of my talk. Neil Smart did a survey of European surgeons, colorectal surgeons, around how many of these operations they do a year. And it's the truth, and also pretty sobering, that 3/4 of them do less than 5 of these operations a year, and only 1% did more than 20 in a year. And 20 is an important number in colorectal surgery because it's the bare minimum number of cancer operations you can do and remain current as a cancer surgeon. So for parastomal hernia, it's just not considered, but it's something that we're doing an awful lot less of. And this paper, I know it's very busy, and I know from the back you might have difficulty seeing it, but I could just point out the key bits. It's from Neil's unit in Devon and Exeter. This is a unit that specialises in parastomal hernia repair and also has a particular interest in Sisyphean challenges. And this is a very honest paper, which is the best, about doing recurrent hernia surgery for parastomal hernias and just how poor and difficult that can be. And basically pointing out that firstly, the best repair is the first one you do, getting it right first time. That's what this is here. So although the hernia may come back, if you do it but well the first time, you reduce the chances of it coming back again. But once you've had to repair it more than once, then the chances of it recurring become much higher. But the other thing that's hidden in the paper that's really relevant is this. So Neil is surgeon C, and he did 26 repairs, and he talks a lot about parastomal hernia. And his other colleagues in there, including Ian Daniels, that some of you know, are also doing a number of repairs. But these data are over a 9-year period. So even in an expert unit doing parastomal hernia, none of them are doing large numbers of that repair. So does surgery actually make this situation better? If you have a parastomal hernia and you have any one of these symptoms, and they're all the ones that you might think sort of bearing down, pain, the look of it, the inability to get your bag to fix, problems with your skin, leakage, all those kind of things that are really relevant to everyday living with a stoma, I'm told, because I don't have one, but I can imagine those are the things that are important. Does doing an operation change any of that? And the answer is that it does for pretty much every single symptom at the sort of 6-month mark, with the exception of things that are related to the way that the stoma sits at the skin surface, which is leakage and skin problems, which is more to do with the way the stoma was formed in the first place rather than the hernia itself. And this, again, a very busy slide, but it's really relevant to what I think our clinic shows. So just bear with me. It is from Denmark. It is the National Hernia Registry, again, looking at parastomal hernia. And what they declared very early on when they started the database is that they were shocked at how bad their outcomes were for emergency parastomal hernia in a good healthcare economy like Denmark, with a mortality right up in sort of 6-7% and a reoperation rate that was really unacceptable, up at sort of 50%. And they vowed to change it. And the way that they vowed to change it is to basically speak to their colleagues and encourage them to only perform this surgery in 5 dedicated centres. So you could do it in other centres, but they encouraged it all to come to these places. And they defined the point at which they'd achieve centralisation as more than 70% of these operations just occurring in those 5 hospitals. And that's when they got to 2016. So this is the increase in operations being done in those centres. And the change to all of the surgery that was going on for parastomal hernia was that more people got offered keyhole surgery, less operations were being done as emergencies because they were being done as a planned thing. And the bit that's hidden in the paper is that more of the patients that had been turned down for parastomal hernia surgery before this centralisation were now being offered operations. And that included people who initially were thought to be unfit for surgery. And again, all of you in the room will have undergone consent, and I've only done it once in my life, and I was in agony at the time, and I really just want them to get on with the operation, to be frank. But the problem with consent is, unfortunately, it is often unidirectional. It is directed from the surgeon telling the patient that this is what it is. And it shouldn't be, of course. It's a two-way conversation. It shouldn't just happen on one day. And for something like parastomal hernia, it doesn't have to happen in the large part at any speed. It can be discussed at length and many times over. But this paper, which is really about incisional hernia, is so relevant to consent in parastomal hernia, needs to get away from the surgeon's viewpoint and needs to involve the patient at all steps, and then to go through all those 5 steps so that the patient's at the centre of that decision making. Because sometimes the reason for not doing the operation is it's unlikely to help you, and that needs to be discussed between you all. So we get to a point where a patient has a parastomal hernia, they are there, and I think it's good practice to have a stoma nurse present as well, and for us to then discuss, like, what are you going to do? So the first question is it possible to live like this? And are there things that we could do that don't involve any significant risk, like an operation? And they are the sort of weight loss, health style management, and hernia support and structured core strengthening exercises. But it may be that doing an operation is a better option, and that needs to be discussed. And then if that answer is yes to the surgeon, are we actually the best person to do it? I mean, are you actually doing 20 or so repairs a year, and are you up to date with all the latest techniques? And if not, and if you are, great, and if you're not, maybe you should give it to a colleague. And if you are going to do an operation, you need to tailor that to the patient, because there are different operations that have different reasons for doing them. Now, this slide is a version of a slide that Natasha and I put up at the Association of Coloproctology. We had a parastomal hernia session at lunchtime, and there was standing room only, and we wanted to challenge the people in the audience who were colorectal surgeons. We said that, historically, there's a very high risk of recurrence, that it's important that the repair, the first one you do, is the best. And we said that if this was cancer surgery, most of you in the room would not be allowed to do it. You would be stopped because you're not doing enough of them. There's no MDT, as it happens, for parastomal hernia, but we can create that in a clinic by having a stoma nurse, a patient, relatives, and anybody else that's important to the patient there. And in addition, just because everyone can do it doesn't mean that we should continue along that route. Maybe it would be better if it went to people who actually were really minded to give a high quality, high volume service. And that led to us thinking, well, what if you could change all of that? And that leads me on to the bit that Gordon alluded to at the beginning, which is the development of a specialist parastomal hernia clinic. To my knowledge, this is the only one in the country. Might shock you to hear that, but it's true. Neil does have slots in his clinic that he carves out for parastomal hernia patients, and he sees them with his stoma nurse, but it isn't a specific parastomal hernia clinic, and I don't know of anybody else that's doing them, but if you do, let me know. And the reason that I spoke to Gordon and my other colleagues about why we should do it is at the time there were 10 of us in the unit, and most of us were performing 0 or 2 repairs a year. It struck me that, in the same way that not all of us do cancer and not all of us do inflammatory bowel disease, not all of us needed to be doing parastomal hernia. And so I asked my colleagues if they would be interested in setting up a service. And not one of them put their hand up. But one of our general surgeons did, and one of our general surgeons who actually is a real whiz at laparoscopic and minimally invasive surgery, and also did train originally as a colorectal surgeon. So we said, okay, well, look, let's set this clinic up. Luckily, those of you that know our hospital, we have an amazing stomach care department. I'm sure they're amazing everywhere, but ours is amazing. And they were very willing to join in with us. And we felt that by doing this, we might get better at managing parastomal hernia. We thought we could reduce variability. And as was mentioned this morning, reducing variability is the way that you improve quality. And we also, it also helped our stomach care department because our stomach care nurses were forever, and it was born out of them being good. It wasn't something that we were unhappy about, but sort of just ringing us up when they happened to have a patient in their clinic saying, can you just pop down and see so-and-so? And it struck me that, why don't we create a forum where that patient can come and actually have a proper appointment? And the other thing that I thought was very important in it, having dealt with the kind of patients that Gordon and I deal with that travel across the country to see us, is to give them plenty of time. Because at the end of the consultation, that may be all they needed, was just a long chat with somebody or some people who were prepared to give them all the information that they needed that they hadn't got from where they'd been. So myself and Andrzej Kaczynski, a general surgeon, we set it up. We've got different skill sets, but that helps dealing with this. And at our clinic, we always have a stoma nurse, and we made our stoma nurses the gatekeeper of the clinic. So what I mean by that is no one gets into the clinic unless the stoma nurses say, but that's brilliant because they know who in their community is having problems and they bring them in. And they also look at all of our referrals that come from elsewhere. Sometimes they ask us for our opinion as well, but generally speaking, they triage all those appointments. And when you come as a new patient to the clinic, you'll get an hour minimum of our time. We started it in May of 2022. We do it monthly. We thought that would be enough. It's absolutely inundated. Maybe after this talk it will be worse. But we made a point, because I've said how the problem is everybody's looking backwards. We made a point from the outset that we collect all the information on everybody that comes to us and we follow them prospectively, not retrospectively. And we also introduced a novel patient-reported outcome form called MyMop. So patient-reported outcomes and patient-reported outcome measures are a very useful way of working out whether the thing that you've done, and it might just be as simple as advice, whether it's had any impact on the people that you're dealing with. But the problem with them is that historically, almost all of them are surgeons thinking, right, okay, well, the biggest problem for you is X, and then writing a questionnaire. And of course, that's nonsense, because, how do I know what a problem that somebody with a parastomal hernia might have is having, because I don't have one. So instead, what we do is in MyMop, and it's, sorry, a little form here, but it's really simple. The patient sits down with a stoma care nurse when they come. The surgeons are nowhere to be seen, and they're asked about what it is in the last week, what symptom that they've had that has been particularly troublesome for them. And it can be whatever they say, doesn't matter. And then we ask them to rate it on a score. This one says 1 to 7, but our score is 0 to 6, where 0 is it causes me no trouble at all, and 6 is the worst it could possibly be. And then we ask them about a second symptom, and we ask them about an activity that they like doing, which of course is different for all of us, but it could be gardening, it could be going to work, but whatever they put down, they then rate how their symptom has affected their ability to do the thing that they like to do. And then we ask them about their general well-being, and we ask them about anything else that they would like to put down on there. And we collect that information, but we've not been doing it from the outset of the clinic. So we've only got information for MyMop for about 50-odd patients. So it's a runaway success in the sense that we've had loads of referrals. We have had a few people that didn't attend, including, really sadly, a patient who died from a strangulated parastomal hernia before they could get to our clinic. And we've had 5 patients who came to the clinic who actually didn't have a parastomal hernia. They did have other hernias, but they weren't around their stoma. And that means that we've got 114 patients to look at. So you can see that the age, I said age is a factor, is it's a slightly older population. And you can see that smoking, which is connected with parastomal hernias, is being a smoker or an ex-smoker is slightly overrepresented in this group. And also that, generally speaking, people who have parastomal hernias are people who also have a higher body weight or body mass index. We grade on a scan the type of hernia that they have. There will be a test on this later, but just so you understand that the concept of this grading scale, which has its faults, okay, but it's just really simple, is that things over here generally can be fixed with smaller operations, particularly keyhole surgery, and things over here tend to be much more complicated. And before I started doing this clinic, Gordon and I really spent most of our time doing these kind of things that were big all-day operations. And very little of the sort of smaller things. So in terms of our Early Hernia Society grade, what we were sort of bowled away at is that we started getting, more than half of our patients have really early, small but symptomatic hernias. And if you take you back to the slides that I showed you a little while ago, are these not the people that we should be seeing and sorting out, because we might be able to prevent them from having a bigger problem later on. And actually, the other thing that came out of it is I suddenly realised I don't have an operation for these small hernias, which is where Andre came in because he was doing the keyhole surgery. Our patient group mirrors what I've said before, that people with endocostomy more commonly get parastomal hernias than endoileostomies. And because we're a cancer centre for bladder cancer, we get ileal conduits. So we've got some patients from that group as well. And these are our outcomes. So if you include the people who we send off for either more investigations or ask them to lose a bit of weight before we're prepared to operate on them, more than half of the people that come to our clinic are offered surgery, which, as you can probably appreciate from what I've told you, that isn't what happens in the sort of normal population. There are some people that we manage conservatively, sort of watch and wait, but that isn't because necessarily they're not fit for surgery. That's often patient choice. And we've discharged some patients after a period of follow-up. And we've also repaired a bunch of patients who had hernias but didn't have a parastomal hernia, just because we do hernia surgery as well. And this is the other big learning point for me about parastomal hernia, is the symptom burden amongst this group of people when we mark it out of 6, so everybody scores everything badly, and the amount of suffering that there is with parastomal hernia, particularly pain, and how it interferes with their mobility. And that's also borne out with symptom 2, so that when they put 2 symptoms down, pain is by far and away the problem, and it's a really unpleasant sort of aching, nagging pain that really bothers people. And when we talk about well-being, again, we get a lot of people whose well-being is severely affected by their parastomal hernia. And in terms of surgical outcomes, as I say, we had to develop a much bigger program of sort of laparoscopic surgery. We've operated on 39 people in that time. It would be more if we had more operating space. But so far, we think our outcomes are quite good. It's a very short follow-up, so far too early to call it. But we've had a recurrence in a guy who has a job that involves lots of heavy lifting, and I think that might be relevant to why it developed. We've had some patients with wound problems, and one of the very first parastomal hernias that we did keyhole laparoscopically, we didn't pay so much attention to remaking the stoma, and the stoma's retracted, and actually he's got more symptoms from that than he did from the hernia, which goes back to the importance of getting the stoma made just right. So our learning points are that obesity and smoking are overrepresented in this patient group, that at least 60% of patients actually warrant having an operation, and well over 60% of the people that come to us are early symptomatic hernias that warrant surgery. And that's completely changed the way that we manage parastomal hernia in our hospital. So we can say parastomal hernia is common. It is a quality of life issue, and I think if surgeons now stop worrying about recurrence, because that's the thing that surgeons think about, but isn't necessarily important to patients, if we think about how all those symptoms interfere with people's quality of life and how the surgery might improve that, then we would think about surgery for it differently. We've got to have the patients in the middle of this discussion, and we want to sort of carry on collecting the data. But so far, our clinic mirrors that Danish data, and I hope that what it will also do is reduce the number of patients presenting as emergencies because they're being dealt with in a much more planned and systematic way. And finally, I'll hark back to Brian Brook and say that we should reject second-rate surgery, we should challenge dogma, and we should strive for better. Thank you very much.